Good afternoon, everyone. Welcome back to the DBMI seminar series. Today's speaker is Saba Akbar. She is a registered nurse with a master's in biomedical and health informatics from the University of North Carolina at Chapel Hill. She has worked as a surgical nurse, nurse instructor, and patient safety coordinator at different tertiary care hospitals overseas. During her time in North Carolina, she worked as a program coordinator at the Carolina Digital Health Research Initiative. She also is a certified professional in healthcare quality. Her previous research work has been in the areas of missed nursing care and mobile health apps. Currently, Saba is enrolled in the PhD program in Health Innovation Program at the Center for Health Informatics, Australian Institute for Health Innovation at Macquarie University. Her project looks at ways to integrate artificial intelligence into computerized decision support systems for nurses to make them more efficient. So with that, I'll hand it off to our speaker. We'll do about 50 minutes, 45, 50 minutes, and then Q&A. So yeah, we get started.
Right. Hi, everyone. Thanks, Shreyas, for the introduction and thanks for the opportunity. I am excited to be here speaking to you all about my PhD project. So my talk will be around what I've done so far and what are the plans, essentially. So can you guys see the screen? But it's not the slideshow, is it?
No, we could see it before there. Give it a try again.
How about now?
Yeah, that looks good.
So do you see the screen or do you see the notes on screen?
I don't see the notes. I think we're good to go.
Okay. Right. So my project is around evaluating effects of automation in nursing decision support systems. This whole project comprises of multiple studies that I will talk about today. Like Shreyas mentioned, I am from Macquarie University, so I'm a PhD candidate there. My primary supervisor is Associate Professor Farah Maghribi, and my associate supervisor is Dr. David Lyle. Both of them are experts in patient safety and human-computer interactions and studying more about how consumers and users interact with technology. I've got all other people to give my gratitude to. Right, so in this talk, I will be walking you through some basic concepts in nursing practice, automation, and information value chain, which kind of will set ground for my studies that I'll talk about later. Right, so starting with the nursing care process, and those of you who are a nurse here will identify this cycle like in an instant, I'm sure, because this is called the nursing care process, the cyclical process that you see on your right, and it's literally the first thing that we learn in undergrad nursing curriculum, and it stays with us throughout because it is so important to the work we do in our clinical practice. It essentially has 5 sequential steps, starting from assessment, which means acquiring necessary patient information, diagnosis or problem identification, as we call it here in Australia. There are these diagnoses or these problems are different from medical diagnosis, and they come from standard nursing terminologies. These problems can be actual, which is something that patient has at this point in time, or potential, which is something that patient might be at risk for. Once the problem is identified, nurses are then supposed to plan outcomes, implement interventions, and then evaluate effects of our actions. Now, while doing all of this, there are several decisions that a nurse has to make. And Thompson et al. Describes these decisions into broader groups that correlate very well with our nursing care process. So the most important decision the nurses make that eventually kind of kickstarts this whole process is when to assess and what to assess. So which assessments are required for their client and what mode of assessment to use. Then once they have the assessment sorted, they classify and analyze patients signs and symptoms and other relevant data as a basis for diagnosis or problem identification. And between assessment and diagnosis is a subtle but this continuous decision of choosing to seek or not to seek further information before making a final decision. Once the problem is identified, there are decisions that involve choosing among alternative interventions and basically choosing which resources to allocate where, what management strategy is most likely to prevent recurrence of the problem. And then comes the experiential or understanding decisions that relate to interpretation of cues in the process of care. And again, while reaching to this stage, nurses are constantly deciding ways of delivering information and ways of receiving information from patients, families, and colleagues. Sometimes these decisions are specifically related to the communication of risks and benefits of different interventions and prognostic categories. So overall, the nurses are usually taking several decisions with each step of their practice. Gladly, we do have systems in place that support our decisions. So these are programs that help nurses who are the users of these programs make informed decisions. And these decisions are usually made on the basis of existing knowledge and individual patient characteristics. We call them decision support systems. And there are several available for nursing practice. You can see some here as examples. So we have assessment forms, we have screening tools, care plans, care pathways, observation charts, symptom monitoring sheets. And these are just to name a few of the decision support systems that we use in our nursing practice. Interestingly, the functions of these decision support systems can vary from only presenting data to users up to actually taking action on behalf of the user. And this brings us to the next concept, which is of automation. Automation can be very easy way described as full or partial replacement of a function that was previously carried out by a human operator. It implies that automation is not all or none, but can vary across a continuum of levels. And what you see here is kind of a levels of automation starting from very basic 1 up to 10, with the lowest level meaning the computer offers no assistant, which is manually, humans are supposed to do tasks manually. So the computer is there, the systems are there, but it's the human that has to make most of the decisions. And it can go up to, you see here the lowest level, it can go up to computer suggesting or recommending decisions to the user, and humans actually deciding and then computer implementing it. At the highest level of automation, the computer decides everything on its own. So the computer takes the decision without intervention from any sort of from human. Now, these levels, while it looks very simple, it's not, because what you see here in these levels are kind of output functions. So we are saying, what will the computer do when we have to make a decision? It's not talking about what happens before the decision is made. So what happens when we are gathering information? What happens when we are analyzing information? So this part of the concept only talks about after a decision is ready to be made. The other way of looking at how automation is applied into healthcare, or in generally in other industries as well, is to look at the continuum of information processing. So when a human processes information, we follow certain stages, and Parasurman and his colleagues actually define these stages into information acquisition, which is the first stage of gathering data, either by sensing it or by kind of registering it from other sources. So an example could be an ultrasound probe, which we can, like humans can reposition and gather data using that device. The second stage is information analysis, which is conscious perception and manipulation of acquired data. So using cognitive functions like memory or inferential processes, And automation at this stage could be seen as, for example, risk calculators or prognosis prediction models. So what's happening here is actually the information that we have acquired is now being processed that can then be generated into a decision format. Now, the third stage is decision and action selection, which involves selecting actions from among different decision alternatives. For example, checklist of decisions to take, in the list of interventions that can be taken for a patient's condition, or a triage system that allows users to choose from a recommended actions. And the final stage in this chain is action implementation, which is actual execution of action choice. So if you look at these four stages, the first two are more about input functions, whereas where the system is actually gathering information, and then the last two are about decisions or output functions. Important to note here is that automation doesn't have to be specific to either of these stages. In fact, automation can happen anywhere across the line, or it can be adaptive, meaning it can vary in level and type depending on the requirement of situation. Now, going back to the decision support systems we talked about earlier, over the last decade, we have witnessed continuous evolution from paper forms that required manual input of information from users and manual risk calculations to electronic form. Now, paper forms and electronic forms, the difference is just that when we were in an era of electronic forms, what we were doing was essentially taking paper forms, typing them into computer, saving into editable format, and that was it. So it's electronic form is essentially copy of paper form. Both these formats are static in nature, which means they can't update themselves. Whereas we're now moving forward to automated systems, which are integrated within EMRs, patients' medical records. They at times capture data on its own and may require manual input of new information. And they're most often dynamic in nature, which is they have the tendency, they have the capability to update themselves without any human intervention. With this evolution, we also see increasing opportunities for automation. So, of course, within paper form, the chances of automating or the opportunities to automate would be minimal, whereas as we go on further towards real-time systems, towards systems that are integrated with health records, we can see more opportunities for automation. And this is actually where my project comes in. So I am super interested in looking at how automation can be integrated, how we can use tools of artificial intelligence into nursing decision support systems and make changes in the practice. So what my project does is it has multiple stages, multiple work packages. The first one is literature review. So I started with looking at the current landscape of decision support systems in nursing and looking at what is the evidence on automation. Are the current systems automated in some way? Is automation affecting any of the outcomes? Following up to the literature review, the second work package that I will discuss within this talk are interviews. So talking to nurses about their perceptions of existing decision support systems. What are the challenges? What are the barriers? How can we improve? Do they see automation happening in some way or the other? And finally, designing and testing a simulated decision support systems that uses forms of AI in controlled environment to test the effects on risk identification and nurses decision making. And this has happened, these three packages have been progressive in nature. So one has led to the other, and we'll see it in a minute how that happened. So the first part of my program was systematic review, where I looked at automation in nursing decision support systems. and the effects on decision-making, care delivery, and patient outcomes. And I'll tell you in a minute where these outcomes have come from. We used preferred reporting items for systematic reviews and meta-analyses as our review framework. We started looking at the literature in October last year. So that was when we did the first search, and we looked at published literature for the last 5 years, starting in 2014. And then we updated our search in April 2020. And we looked at several databases. We kind of, the main search terms were around nursing, decision support systems, and all these listed outcomes. And these outcomes are actually rooted into this information value chain, which starts from when a user interacts with technology. It could be any form of technology, but it starts with when a user kind of goes to the system and uses it in any form. In return, when a user interacts with the system generates information that is then received by the user. Now, that information may have the tendency to change decision. It could be a positive change, it could be a negative change. The changed decision then can change how the care process is delivered. Again, it could be positive, it could be negative. And then depending on how the care process was, patient outcome can be changed. So this is the information value chain that we use as kind of framework to evaluate effects of decision support systems. So I'll be looking mainly at how information that is received from decision support systems can change nurses' decision, care delivery process, and patients' outcomes. And an example to understand this process is nurses accessing decision support system. It's as simple as nurses looking for, say, assessment forms within the system, or nurses entering data. In return, the decision support system generates analyzed information or gives away represented or graphical form of information. That's kind of information received. When a nurse looks at that information, they can use it to change their decision in a manner that benefits the patient. So they are able to identify risk status or problems on nursing diagnosis, and then perform interventions that are timely. So in a way, there is an impact on care process. And finally, as that change, patient's outcome is impacted. So for the review, the inclusion criteria was very basic. We looked at electronic decision support systems, so studies that talked about electronic decision support systems. We were not looking at paper-based systems. And these systems had to be used exclusively by nurses. So we found a lot of studies that had multiple users, so decision support systems being used by clinicians, nurses, say physiotherapists, all the healthcare team members. But we were mainly interested in nurses because we feel like the nursing care process is very unique to nursing practice, and how nurses would interact with the systems would be different from how other professionals would do. And then we included studies that mainly discussed or reported outcomes along the 3 groups that we were interested in. So this is the diagram explaining our article search and retrieval process. We screened a total of 568 titles and abstracts, and this is combining both the initial search and the updated search. The screening and full text assessment were performed by 2 independent reviewers, and we used Covidence and EndNote to process this. Now at the end of it, we included 28 studies. All of these studies evaluated a different kind of decision support system. So what we found was that most of the studies were quasi-experimental. So they tested the system in kind of a snapshot. So they went in, implemented system, tested some part of it, and that was it. We had 6 studies that were randomized controlled trials, and 5 were others, including a couple of observational studies and interviews. We used Cochrane bias tool to look at RCTs. Most of the studies that were included were published in either 2016 or 2018. We don't really appreciate any particular trend in the year of publication, but it was just interesting to see that there has been variation in how much work has been done along the lines of nursing decision support systems over the years. 19 of our included systems were implemented in short-term care units, which were either acute care units, for example, emergency departments or urgent care units, or surgical units or medical units. 8 of our decision support systems were implemented in long-term facilities, which means nursing homes or community practices. And there was 1 that was implemented in both kind of settings. Most of the DSS were used by registered nurses. There were 3 that were used by nurse practitioners. Nurse practitioners had a bit more authority in terms of performing nursing tasks. And there was 1 system that was being used by midwives. So we looked at tasks performed by included decision support systems, and the most frequently studied systems were responsible for triage, that is recommending levels of care needed for patients, followed by nursing care plans. We had systems that looked at medication management, so either calculating doses or administering medication. It could be either of the function of medication management. There were 3 systems that looked at specific symptom management, for example, headache or backache. There were also, again, 3 systems that looked at health promotion and maintenance, and these 3 were implemented mainly in long-term facilities, where these decision support systems were used to screen patients for chronic diseases. In terms of nursing care process, most decision support systems facilitated assessments and interventions. So, for example, decision support systems would provide a list of questions or symptoms for a nurse to go through while they're assessing, or they would help narrow down list of actions. So these 2 were most frequently found functions of nursing care process implemented within the decision support systems. The least commonly supported step was evaluation. And interestingly, only 2 decision support systems looked at all the steps altogether. So they covered the entire cycle. Now, in terms of effects, we looked at how decision support systems were found to be impacting nurses' decision-making. And we found that, number 1, these decision support systems helped reduce variations in care plans. So when the decision support systems were implemented, nurses were found to be doing similar actions across the setting. So variations decreased. Compliance had kind of mixed reports. So nurses would agree with what the decision support systems recommended them between 20 to 87% of time. So this was a huge variation. We found reports of improvement in problem identification, and importantly, the time required to make decisions decreased. There were also mixed reports on how documentation was done, whether or not evidence-based practice was documented and implemented, with some studies suggesting that decision support systems improved it, whereas others said either no improvement or it kind of decreased the amount of documentation, or it decreased the amount of care plan items implemented. There were also reports of how decision support systems resulted in inconsistent behaviors of nurses. So when the system was implemented, you would see a spike in positive outcomes in the way nurses would implement evidence-based practice, but over time, it reduced. And there were also reports of how other factors, for example, nurses' work environment or their experience or clinical judgment have importance in making decisions. So most of the time, it wasn't just the system that the nurses would use to make the decision, but they would use their own clinical judgment. They would factor in all other kind of things happening around them while making decisions. In terms of care delivery, we found reports on how high-risk patients received care sooner with the implementation of decision support systems. So that was a huge positive outcome reported in a few studies. There were also mixed reports of how decision support systems were dealing with errors, with some studies reporting decreased errors, especially around medication dosage calculations or care plan documentation, where some studies reported no significant changes or, in fact, increase in error rates. Number of topics covered and extent to which health education was imparted was also found to be increased as a result of system implementation. And there were, again, mixed reports of how systems impacted medication administration. In terms of patient outcomes, readmissions were found to be reduced. So that was one positive outcomes across all studies that reported readmissions. Incidents, so there were studies that talked about falls incidents or pressure injury incidents, and they would report either decreased number of incidents or no change. Length of stay was found to be, again, either increasing or remaining unchanged. So again, mixed reports. With the use of decision support systems, studies reported that more patients were screened for and managed for chronic conditions. So the area of health promotion was positively impacted. Now, looking at the automation, so these, up till now, these were the outcomes that we looked at individually. But in terms of automation, we found that all the decision support systems that were included, all 28 of them, had some level of automation along the lines of information analysis and decision selection. There were 5 systems that automated information acquisition. So what they would do is they would take information from patients' medical records and without having nurses to manually enter information in each system. And there was just one system that automated action implementation. And here the action was documentation. So the system would document whatever action nurses selected in the patient's medical records by itself. So those systems that analyze information were also the same systems that give out a list of alternating decisions for nurses to choose from. The systems that automated information acquisition also did the next 2 steps. So whatever information they acquired, the system would analyze it on its own and then generate a list of decisions. Similarly, the one system that automated action implementation also did analysis and decision selection. Now, in terms of how automation impacted outcomes, we found that within decision-making outcomes, there was more positive impact of automation as compared to the other 2 areas. So decision-making, we found more positive outcomes. Care delivery was the second, and patient outcomes was like the least impacted by automation. What we learned from this review was mainly most systems automate information analyses, and this was like a clear finding that every system that we looked at was automating to some level information analyses and decision selection. We also found that planning, which is identifying outcomes, and evaluation are the least focused areas. So what these studies were doing were just going in, taking a snapshot of events, implementing system, and then coming out. So not doing the entire process. And also there's huge variation in how decision support systems are implemented. what kind of variables are tested. So there was a huge range of what kind of measures were applied, even to look at the same variables. So how they were tested was also very different. So it was kind of an apple to orange comparison. And there wasn't any similar kind of standardized reporting methods or testing methods for decision support systems. This brings us to the next study, because after this systematic review, we found that there is a gap in terms of automation in nursing assessments and reassessments. That is one area that was understudied. And decision support systems in nursing are mostly studied in outpatient and emergency settings, which was the short-term care facilities. Decision support systems, like, it also depends on how it was implemented and tested, but most of them were based in the short-term care setting. So now we wanted to know whether automation in clinical decision support systems improve risk identification and nurses' decision-making. And well, there are several risks. There's a whole bunch of risk assessments that nurses have to perform, but we chose two, which were pressure injuries and falls. And we chose these two because they are on top of the list of hospital-acquired complications within Australia. And they have been on the top for quite a few years now. We get a lot of falls incidents within our hospitals. This is the data from 2016, where we had around 34,000 falls that resulted in harm. So there were other falls that didn't harm the patient, but this is the number for patients who were harmed as a result of falls. 84% of these falls were in public hospitals. So we have like public hospitals that are governed mainly by local health districts within states, and then there are private settings. 40% of all these injuries that resulted from falls led to deaths, and of course, when a patient has a fall, that would ultimately mean more interventions, meaning more costs. It's the same for pressure injury. So we had more than 4,000 pressure injury incidents within a year in public hospitals, and it resulted in 9.7 injuries per 10,000 hospitalization. So these two are kind of our focus areas and have remained on the top, like I said, for some time now. The good thing for my benefit, or for my project's benefit, was that these two problems are very much nursing focused. So nurses are responsible to assess and reassess for these two conditions. There are also prevention plans in place for both the problems, and they have validated screening tools. And most importantly, the screening guidelines are very, very similar. The way falls are assessed, the time intervals is very similar to how pressure injuries are assessed, although the tools are different, but the process looks very similar. So we started on talking to nurses. This was the second part of the project, where we wanted to, I wanted to talk to nurses in practice within Australia and talk about what they think of decision support systems, what kind of tools do they use, what are the challenges if they're not used, what could be the barriers, what do they recommend doing, if they see opportunities for automation and all of that sort. So we started interviewing nurses about their perceptions of current decision support systems for the two problem areas that we chose, falls and pressure injury risk assessments. This study was approved by Macquarie University's Human Research Ethics Committee, and it went through several kind of reiterations, because it was initially planned to be a face-to-face interview, individual interviews and focus groups, but then pandemic happened, and then we had to change it to, we had to take a break because nurses were busy in hospitals, and then we changed it to online interviews. Our recruitment was done via social media, personal networks, and snowball methods. The inclusion criteria was, we wanted registered nurses, basically registered nurses who were working on bedside or who were, say, clinical nurse consultants. Clinical nurse consultants are kind of nurses specializing in any one specialty, and they overlook all other nurses within the ward. So for example, a urology clinical nurse consultant would be responsible to supervise all the nurses working within urology wards, and patient safety officers. We invited nurses who were working in Australian hospital. It could be any Australian hospital. And we were interested in talking to people who were working in adult non-critical setting. We did not include emergency departments or other critical settings because by definition, patients who are admitted in critical care settings are at high risk for pressure injuries or falls. So we wanted to talk to people who were looking at patients who come from all kind of acuity levels. And so these interviews were recorded, audio recorded and self-transcribed. They were between 30 to 45 minutes. Now, so far we've done 14 interviews and it's still ongoing. So from the looks of it, we'll be done with the next couple. So far we have interviewed 8 registered nurses, 1 CNC, which is the clinical nurse coordinator, 1 nurse unit manager, and 4 patient safety officers. And there was a huge variation in work experience. We interviewed a couple of novice nurses or fresh graduates, and there were a few who were very, very experienced. They come from all kinds of specialties, mostly from med-surg, but we had representation from geriatrics, urology, and mental health. We did have 3 casual nurses. By casual nurses, we mean nurses who are rotated. So they might be someday in med-surg, the other day they might be in geriatrics. So they rotate, they don't have a fixed placement. Now, we asked these nurses about the current risk assessment workflow, and although we had already seen the guidelines prior, we wanted to see what's happening in the practice, and we found that initial assessment is usually done within the first 8 hours. So when a patient is admitted, first 8 hours, you have to do initial assessment, and this was similar across all participant responses. Now, once the patient is assessed for a risk for falls and pressure injuries at the time of admission, the next assessment is done depending on whether the first finding was high risk or low risk. So if a patient is, say, medium to high risk, they would be reassessed either daily or per shift. So this was kind of slight variation in different responses. So some participants said they were required to reassess daily, while the others would say they would reassess per shift. But for low-risk patients, it was again, slight variation. Most of the participants said they would reassess weekly. Their hospitals required them to reassess weekly. And there were a few that said there's no such requirement, and then we reassess when there is a change of condition. Most settings have days in place. So for example, the hospitals here do Waterloo. Waterloo is the risk assessment form for pressure injuries. So they do Waterloo Wednesday and Falls Friday, so that it's easier for nurses to remember when to do what. And in some settings, it's very, so everybody has to do it. So there was this participant who verbalized that even if the patient is admitted, say on Tuesday, and we do the initial assessment on Tuesday, we have to do Waterloo Wednesday the next day. So there's no leniency in that. Whereas in the other hospitals, it wasn't that strict. We asked nurses about what kind of decision support systems they use. 3 of our participants were in practice of using paper-based forms, while all others who used electronic forms. This kind of tells us where we are in terms of transitioning towards electronic and more automated systems. For falls, hospitals used different kinds of, so these are all validated screening tools, Ontario Modified Falls Risk Assessment and Falls Risk Assessment and Management Plan. These are all validated tools, but depending on the settings, different hospitals use different kind of forms. For pressure injuries, everyone used Waterloo Pressure Ulcer Prevention Form in combination with skin integrity assessment forms. Right, so we asked nurses about their perception of challenges. So what they find is kind of barrier. And the first one was always time and work pressure. So because nurses are so tight on times, sometimes they feel like they're taking away time from patient care, doing all these documentation and filling out forms. So time and work pressure was the first challenge that came across in most of the responses. The other challenge was lack of value realization. This is interesting because all the participants, when asked whether or not, what do you think of risk assessments, they would say, oh, we value risk assessment, like risk assessments are important, they are meaningful, we have to do it. But then they would look at the decision support systems or the forms they use as checklists or just there to be done, just tick boxes. And they verbalize not being able to realize the value of each question within the forms. There were also kind of reports of how I assess my patient can be different of how another nurse would assess my patient at the same time. And that was because the questions asked within the forms were very subjective. So the way nurse A would perceive it might be different from nurse B, which leads to variations in decisions. So some nurse would score a patient as 6, while others would score it as, say, 7 or 8. There were also gaps identified by our interview participants. So gaps in the risk assessment form. So there was this report of a patient with cardiac condition. So it was a young patient, no such risk factors. So on the form, it would say low risk for falls, but in reality, because of the cardiac condition, that patient was at high risk. But because the form doesn't capture that kind of conditions, the patient was still marked as low risk. So there are gaps in how, what factors are captured by the assessment forms at present. There are also gaps in the management plan part of it. Now we asked nurses to tell us whether or not they would want to continue using the same forms, and if not, what would they recommend? Interestingly, everyone said they would want to continue what they were doing. They didn't find anything wrong with it, but they would really, they had some recommendations. So the first one was reduce duplicates, because the system asked them to fill in each form repeatedly when there is a change of condition, for example. They were interested in finding out ways to not do it. So they would end up finding workarounds. So copy pasting, for example, instead of completing each form again and again, which creates lots of duplicated data. So they recommended reducing that and then making it into comprehensive assessments. So they said, for example, right now there are multiple forms and they have to go in and select each form and fill in each of them, whereas they would recommend one single comprehensive assessment that does everything. And mainly because a lot of risk factors are overlapping. And so if you do this, you don't have to do this. So once you assess, for example, patient weight, you don't have to do it again and again for all other assessments. So to avoid that overlapping or duplication again of data, they recommended a comprehensive assessment. Now, to bring it all together, we learned from these interviews that risk assessment for falls and pressure injuries are complex. These conversations were very important for us to realize that nursing dynamics are different. Nurses work in variable shifts. The nurse-patient ratio is different in different settings. There is a workload that is a challenge. There are distractions. And of course, current status of decision support systems is not ideal. We also figured out the points of assessments. That is when a patient is assessed and then reassessed for risk. And what are the risk factors that the nurses are usually looking for? So for example, activity status, chronic conditions, patients, medications, surgery, all of that. And most of this information is available elsewhere within medical records. So you will find medication-related information in medication management charts. You would find surgery-related information in their surgical charts. You would find hydration-related information in their input-output records. So knowing all of this, what now needs to be discovered is how can we leverage existing information? So we said most of the data of risk factors is collected elsewhere. How do we take that information and facilitate nursing assessments? and whether or not automated reassessment clues can help, especially in identifying risks, real-time risks. So because what's happening right now is nurses have to go in and reassess when there's a change of condition. These changes of condition can at times be subtle and not identified in real time. So we are now interested in looking at whether automation can help identify risks in real time and change how nurses decide to intervene then. And this brings me to the third stage of designing and simulated experiment, which is happening right now. So we have designed the system and we plan to test it at the start of next year. With this system, we want to see whether automated information processing can increase percentage of completed assessments. So it's generating more completed assessments. It's reducing time that is required to complete the assessments and then make decision, and whether or not there are errors or missed assessments resulting from automation. Now, how we plan to do is we'll have 3 experimental conditions. So manual, low automation, and high automation. And these conditions will be applied to 3 patient scenarios. In the manual condition, nurses will decide which assessment to do and then, of course, perform those assessments. In low automation, system will prioritize risk assessments for nurses, and nurses will have to perform, whereas in high level of automation and risk assessments, the system will decide, the system will perform risk assessment, but nurses will be able to verify or make changes if necessary. Now for the experiment, this is kind of an overview of how it will go. So we'll ask participants to assess patients for as first encounter. So we'll have 3 patients, 3 patient conditions. The participant will be required to say assess patient A, patient B, and patient C. And then there'll be a change of condition alert, after which the nurses or participants will be required to do a subsequent assessment. So in the manual condition, patient's medical summary with relevant findings will be presented to participants. So participant will be able to read through clinical summary, medication records, vital signs, mental health assessment, all the data that is usually present in medical records. And then participants will be asked to prioritize problem risk assessments and then perform those risk assessments. In low automation, participants, again, will be able to see all the clinical summary, but the system will generate prioritized risk list, and participants will be able to complete it. In the high level of automation, participant will be given clinical summaries, patient information, also prioritized list, and pre-filled assessment forms. Now this will happen twice, which is the first interaction, and then there will be a change of condition, after which the system will update itself and generate another set of risk assessment forms. And we want to see it essentially is so in a way we are automating information acquisition. We're taking information from medical records and generating output for nurses. So we want to see if we automate information acquisition, information analyses, and decision selection, will that result in improved risk assessments? So this, like I said, the experiment will start, the testing will start in Feb next year when we come back from the New Year's break and everything. But yeah, so we're hoping to finish it by June next year and understand how and whether there's an opportunity, honestly, to automate risk assessments, because we really do not need to automate everything that's there in decision support systems, but this will give us an idea of whether there's whether it'll work for nurses, whether there's an opportunity for risk assessment automation, and whether it'll help nurses in their decision making. So yeah, this was it. If I'm open to questions, and yeah, these are my contact details.
Great. Thank you, Saba, so much for that talk. I'll open it to any questions from the audience.
Hi, great job. Thank you so much. I was just wondering if you could talk about some of the challenges of conducting human subjects research in the pandemic, and what you've learned from that and how we can kind of adapt our own research with the lessons you've learned?
Yes, that's a very important question. I remember when pandemic started, I was like, so I had my ethics application ready in March. I was like ready to go in. The plan was to go into hospitals, observe how nurses work, and then talk to them individually and focus groups. But of course, that changed completely. So what we did was we kind of looked at other ways. So the first decision was to not, of course, we can't do face-to-face anymore, so do it online, but then how to do it online? What are the systems that are available? Can we do Zoom? Can we do Skype? What are nurses more comfortable with? So we talked to some nurse leaders within hospitals here to find out what they're using in their practice, and we figured out that Zoom was okay. And then we reached out to the university's legal bodies to figure out whether recording meetings on Zoom is allowed, how the ethical governance will play its part in it. So that took some time, but yeah, so we ended up with, we were allowed to do either Zoom or Skype, depending on the participants' preference. And yeah, so it took a bit of a time, but at the end of the day, we did well. We got the approval to do online things. It's harder for, I would say, nurses to come online and participate in interviews like these because they don't work in office settings, right? So they don't have access to computers in an instance. They have to do it. So I've got participants who would take out time on weekends or on their day offs to talk to me, which is hard. And I understand it from my experience as well. We wouldn't want to speak to a researcher for an hour outside of our work practice, right? So it's hard for clinicians to participate generally in research. So it's taking longer than I would like it to. I would have expected to finish interviews and start testing by now, but that changed. But yeah, it wasn't impossible. It's just a bit of a stretch of time.
Do you feel like it harmed the context of not being in the actual environment in the clinical setting, doing it over face-to-face, in terms of how you were able to probe them or really situate them in the actual context of their care work delivery?
So I personally learned it along the ways of doing interviews. In the first couple interviews, I felt like I didn't ask questions that would have kind of resulted in talking to me more. But I think now I'm more comfortable in asking the questions that I really, really want to ask. What has helped me is my own experience as a nurse. So because I know I come from that setting, I know how it works. So I know what kind of questions I would, or what kind of themes I would want them to touch on. But yes, in an ideal setting, I would want to go in and observe their practice and then ask relevant questions. So I missed out on that part, which was kind of a big component. But I think we have made our way through it.
Yeah, thank you so much. Appreciate it.
Yeah, nice.
Hi, Saba. I also had a question.
Yeah.
So I had a question about like how you plan to perform the conduct the simulations and whether those will be held virtually. And then questions about like how do you plan, what are the outcomes that you plan to measure? I think I may have missed this for the evaluation piece of like the simulation sessions, and how do you think that in like real world setting you would translate that from and evaluate the outcomes? I don't know if that makes sense.
Yeah, no, that's an important question. So what we're doing is, we've built this system already, so it'll go online. It'll be a virtual thing. Nurses will be able to do it at their own time, but they'll have to do it in one sitting. So it's kind of a simulated setting where you go in, there's a hospital environment that you'll see, and you'll be explained how you are assigned to like 3 patients. So we'll explain participants that, hey, so you are a nurse, you are in this setting, you have just come to your duty, it's 8 in the morning, and you have been assigned 3 patients. Now you have to like go in and do what you do in your practice. And once they go in, so you'll see 3 patient windows. They can choose to do whichever they want to do first. And then when they go into that patient's window, it'll look very similar to the kind of medical records they see in their practice. So we've got screenshots from some hospitals within the New South Wales here to see what kind of systems do they see on their screen. Because the idea was to make sure everything else is controlled, and we didn't want to introduce a lot of variations. So it doesn't have to look like an alien system that they have never seen or heard of. So it looks very similar to what they're used to have seen. And once they start looking at patient's condition, there'll be an option to start their task. And when they then select that, the task will tell them like next steps of what to do. What we are actually looking at is whether within these 3 conditions, how nurses assess patients differ. So if the condition is manual, which is when nurses have to decide which assessment form to select and complete, versus a high automation where the system decides which assessment forms are to be selected and completed, is there a difference? Do nurses miss out more on assessments when they're doing it manually versus when it's automated? In the first set of assessments, it'll just be an initial kind of first interaction, first encounter. Whereas when there's a change of condition alert in the middle of experiment, then we'll see whether with this change of condition, are nurses able to pick relevant assessment forms? Are nurses able to decide what assessment forms will be changed, or what risk status will be impacted because of that change of condition? So we're looking at which assessment forms they end up filling. If that assessment form is being filled up to the mark, so it's complete, it's error-free, and then how much time is it taking for nurses to do this whole process? So in real practice, what's happening is nurses, when they go in, they look at the patient, they decide which assessments to do, and then they perform it. So it is very similar to our manual condition at this point. Now we'll introduce low automation and high automation to capture whether that changes how nurses decide to do assessments and then complete the forms. Does that answer your question, Amanda?
Yeah, thanks, Saba.
All right.
Great. I think we have certainly time for one more question.
Do we have nurses here? Do we have?
Well, I was actually just going to ask a question, and I am a nurse, yes, and there are some on the call. We did share this invite with the School of Nursing as well. So thank you for this work. You know, a few years ago, we looked at some decision support that was available to nurses and through vendor-based systems, and most of it really was focused on facilitating documentation and data capture. You know, so the work that you're doing is very important. I was wondering if you can talk a bit about kind of this issue of data capture, right? So you're focused on, can we use the information in real time to help facilitate what the nurses should be assessing. Nurses are by and large capturing most of the data in the inpatient setting, at least in our EHRs. And so can you talk about kind of that perhaps chicken and egg problem that we may have with, you know, using that real-time data if nurses themselves are the ones, you know, entering most of that information?
Yeah, this is a gray area. In fact, I was talking to some nursing leaderships in one of the hospitals here, and we kind of discuss the same things. So there are 2 things. A, nurses is the data that is entered and being captured by, say, the system, who is the owner or who's the producer of that data? So who has actually entered the data in the system, and whether or not that data is correct, how does a nurse identify? So when we talk about introducing AI or technology to capture data on its own? Is the nurse comfortable enough to work with that data that the system has captured or brought in from somewhere else? If the nurse is the one who is entering the data, how comfortable they would be to then deal with the data by themselves, versus if, for example, a doctor has entered, say, allergy status of patient. Will the nurse be comfortable to work on what is entered in another outside of nursing notes? So there are multiple kind of dimensions of looking at how data is captured and how nurses would want to access, what kind of data would they want to access. At this point, within the nursing systems, most of the data, yes, is being captured by nurses. And from the interviews, what I found is nurses are very comfortable in working with the data that they capture by themselves, instead of trusting what anyone else might have captured. So they would want to kind of own that data. They would want to be the one who is getting that data and entering it. But I think there is a bit of, they trust what their colleague nurses have entered. So if it's a data point that's captured by a nurse, other nurses might be comfortable using that to make their decisions, in comparison to if the data is captured by someone else from the healthcare team, and nurses are supposed to use it. So I think it's kind of a trade-off between, do you want to recapture the same data that might have been captured before, versus do you trust the data that is already in the system? So yeah, it's give and take. Depends on what task the decision support system is performing. If it's a critical decision that the system is supposed to work on, then of course the trustworthiness of data would take the lead. Whereas if it's a regular task, if it's something that is very repetitive in nature, not very critical, then a data that has been captured by anyone else on the team should work.
This is Hanjin from NYP. I just have a last comment about that. I think that we are at NYP as developing an AI screening tool for malnutrition. The goal is to replace the nurses screening using the questionnaire, like checkbox, etc. And it turns out that we've been very successful is that we not only replaces basically the nurses don't have to do that screening anymore, but also our accuracy is 10%, at least 10% higher than them, because we did like an AI tool to do the training and the prediction, and also using more data points than the nurses screening does. So I think that I actually, your presentation opened an eye for me, because you are now talking about many different decision supporting tools, not just like one specific ones, as each development of each one tool could be very expensive to start with. So I really appreciate your talk. It's very informative. Thank you.
Yeah, thanks. No, so as part of pressure injury assessments, we kind of also looked at what tools we use for nutrition assessment. And it's interesting to see how all these tools are interrelated. So there are data points that are common across all these forms, but then at this point in the system, they all exist in silos. So nutritional assessment is happening separately. Then there is skin integrity assessment that's happening on its own, and then pressure injury assessment. So all of this happens individually, whereas all the data points are so interconnected. There's so much of overlap in what kind of information goes in. So yeah, thanks for sharing that.
Great. Well, we are out of time. Thank you so much, Saba. This was a really great talk, very informative. We appreciate your time. Thank you.
Thanks so much, Sarah. Thanks for having me.